والآن من موضوع وقاية القلوب لمرضانا وجهازهم العصبي إلى وقاية عقول مرضانا وجهازهم العصبي. يسعدني أن أدعو إلى المنصة الدكتور جاسم الهاشل، أخصائي الجهاز العصبي ورئيس قسم الامراض العصبية في مستشفى سينا، لنناقش كيفية الوقاية من امراض الجهاز العصبي.
اشتغل في السلايد. نعم. Yeah. Many thanks, Tom said, for arranging this great conference. And it's very great actually to have such a meeting, and the talks, they are great. It's really in the afternoon. You have been here since morning, right? And you guys are tired? No? Yeah? Okay. So let's do something here. So can we have everybody stand up? Everybody stand up. Shabab, stand up. Everybody. دقائق stand. بعدين ليش قاعدين بعيد احنا and let's just stretch شوية بس. شوية stretch يا شباب. stretch يا شباب اللي ورا. السعودية عمان. أقول لك شوي. Okay. يلا sit down. Okay. It's very hard to follow the steps. We're going to speak at what time. خالد ترفع العقاب. أنا شاكل راح مجلس الأمة من الأبناء. Okay. Good. Now, what part of the South America will speak Spain? هو بس يسأل أنا أسأل. Mexico. That's my presentation. Okay. Now I was asked. Let's talk neurology now. That's how we talk. Okay. So let's speak about some neurology and some facts. So I was asked about very broad topic, emerging preventive neurological diseases. You can just imagine this from the title. So there are many emerging diseases, and let's see what can we do for them. As you know, the age of the population is growing, or the population is aging. And this is not only in North America and the States and Australia, but it's also in the Middle East. So the population is aging. Like 20 years ago, you listen to the news and people, they die at 69, 65. Now you listen to the news, الأخبار ما شاء الله 80, 85, 89. People, they are aging. But when you see such thing, then the government and the healthcare system, they should have a vision. What shall we do with those people, right? Because they're going to make a lot of the population, a big number of the population. Now this is the census from US, and if you look at the population in 2010, around 40 million of the population, 40 million, they are above 65. What's going to happen in 2000, there will be more than 80 million. The same thing you can applicate it also to other countries in the world. Okay, so the population is aging, and that's an alarming thing for the country and for the healthcare system. We should have a geriatrics floor. Maybe we should have a geriatrician. We have probably 1 or 2 geriatricians here in Kuwait. Not only this, if you look to the burden of the disease, the WHO mentioned what are the disease that's causing burden of the disease, and that's you know, there are many neurological diseases that they are emerging, but I'll try to focus on the common neurological disease which has a high burden in the society and the financial impact. Now, if you look, the highest leading cause of death in the world is ischemic heart disease. Okay, right after this comes CVA. It's the main. Not only this, also the main cause of disability among adults is stroke. It's the major cause of disability among adults is cerebrovascular disease. Now, this is a slide that to share the information with you, that to know the stroke, they are divided to two types, ischemic and hemorrhagic. Hemorrhagic 20%, 10% is subarachnoid, and 10% is intracerebral hemorrhage. Well, now ischemia, I just want to tell you that there is around 30 to 40% of stroke that are cryptogenic, and that means that we don't know what's the cause for those people with stroke. And the commonest stroke for young age group, هذا الMCQs, right? بدينا نعمل MCQs. Commonest cause of cause for stroke in young age group is contraceptive. اكتب البيعيد. It's a cardioembolic, then carotid dissection. Okay, the commonest cause of in young. لما نقول young يعني شنو نقصد؟ يعني أقل من 45. اوكي، هشام موجود ولا مو موجود؟ نقدر نتكلم عربي. Okay, now then you ask me then, Doctor, why are you bringing this issue stroke? Now, can we prevent the stroke? That's the question. Now, when you look to stroke, there are modifiable and non-modifiable. Modifiable, you cannot do anything for them. Age, the risk of stroke just goes higher really with age. Now, the gender, we know that strokes is more among male, but it's more, it's a leading cause of death among female. We don't know why. Race, it's twice high in Afro-American. In Afro-American, we found that they are prone, the dark color people, they are prone to high blood pressure, hypertension. They have a lot of lipohyalinosis. Okay? Lipohyalinosis أول يصير مع diabetes والhypertension، يصير عندهم lipohyalinosis. عشان كذي لما يحوشنا واحد في الستروك باليان أو في الأفرو-أمريكان ونسوي له الكاروتيد إكسترا كرينيال ما نلاقي، بس بالسمول فيسلز في البرين تلاقي عنده. So don't be fooled by normal carotid Doppler. You have to do a small vessel disease. Those usually they have small vessel disease, and we have difficulty in controlling their stroke. Now there are families also history of a stroke like CADASIL. CADASIL is cerebral autosomal dominant arteriopathy with sub leukoencephalopathy. Anyhow, so it's just a disease which it's autosomal dominant, which is causing a stroke. So there are families, for example, also hypercholesteremia. Hypercholesteremia sometimes there's autosomal dominant type, which runs it. That's a risk factor, but we cannot do anything. But we can do many things actually. We can do many things for people to prevent a stroke. Hypertension, most important cause. It's the most important. If you reduce hypertension, you reduce the relative risk reduction is 40%. The relative risk reduction of reducing stroke by controlling high blood pressure is 40%. Cigarette smoking. Also, we know that cigarette smoking is increase the risk of ischemic stroke and also increase the risk of hemorrhagic stroke, and also make people with aneurysm that they are at risk of rupture of their aneurysm. Okay, people actually, many people they are having aneurysm. We don't know that they have aneurysm, but people who smoke they make their aneurysm at risk of rupture more than those people who does not smoke. Atrial fibrillation, big problem. Big problem, atrial fibrillation. Why it's a big problem? Because it's higher among aging population. The population again is aging. We'll see more and more of atrial fibrillation. And I have seen many actual patients of atrial fibrillation and people they are not treated in the right way. It's so devastating. And it's not like any other stroke. It has more mortality and more morbidity and more high recurrence. The recurrence in atrial fibrillation is higher compared to other factors of or other risk factors of stroke. Diabetes, we have to control diabetes. Okay, cholesterol. Now the guidelines before 5, 6, 7 years ago, you should bring your LDL below 2.5. Now you should bring it below 2. So we have to work hard, and we have really many medications. I don't agree. I don't accept any patient to come to my clinic with high blood pressure. Really, I refuse this. Now we have tons of medication in the market to reduce blood pressure. So we should not accept either the patient is not taking his medication or there is a problem with the patient, okay? Or with the doctor. The doctor is not giving the right medication. عندنا وايد كبيرة ما تتخيلون يعني. We should control the blood pressure. Again, obesity, you should reduce obesity, and physical activity is very important. Now, when you come, that's a primary prevention. Now, when you come for the secondary prevention, the patient has if the patient had stroke, now you can do many things. You should give antiplatelet. في طبعا في الماركت موجود الاسبرين في بلافكس وفي اجرينوكس، هذا دواء ثاني. طبعا if the patient is naive عمره ما اخذ دواء antiplatelet, you should go for aspirin, cheap, available everywhere, over the counter موجود. بعدين if you fail, then you can go for Plavix, clopidogrel, okay? Then people they say that there is a drug called the Agrinox, which is it's only marginal، يعني أكثر شوية أحسن من البلافكس الأجرينوكس اللي هو عبارة عن دايبيتامول وأسبرين. Anticoagulation is very important. There is no way to compare aspirin versus anticoagulation حق patient عنده atrial fibrillation. There is no way. الأسبرين يقلل الريسك of stroke and atrial fibrillation by 22. الانتيكوagulation الوافر إن يقللها by 66. Huge difference. You don't see a lot of medication ترى تسوي كذي فرق هالكبر، يعني 22 ل 66 two third. يعني 75 لو تقارن بين الاثنين 75% different. فلا تقول لي أحد على هذا ما ياخذ anticoagulation. Now carotid end atherectomy you have to do it in the right appropriate time. لو patient had a stroke you have to do it within 2 weeks. Okay, especially in May, because otherwise after the 2 weeks of the stroke the risk will become like the other population. So if you do it in the right time within 2 weeks, that's the benefit. But you have to do it in a good hand, because يعني لازم خاصة الناس اللي تسوي شيء critical surgery لازم يصير عندهم morbidity و mortality figure. يعني يقول لك ايش كثر الموربيديتي مع الدكتور الفلاني، يقول لك والله اقل من 3 او هذا، فما ما يصير عنده morbidity وايد. Do you understand what I'm saying? ليش إن في ناس specific who do such thing. Atrial fibrillation, really we need to emphasize on this a lot, because we will see it among your family, we'll see it. وراح تزعل صدقوني، يعني راح تزعل لو يجي أحد من أهلك. I have seen it يعني in one of father of my friend, and he died unfortunately. He had massive MCA stroke and he had atrial fibrillation. He was following in the clinic, and the physician in the clinic he gave him only aspirin. الحين أنا شو أسوي؟ أروح أكلم الفيزيشن ولا يطيح مني I like to joke, but just to keep you with me. Okay. But this guy ما قام يشتغل يا وين الطيار توفى خلاص. This patient but he died actually from massive MCA stroke. And who to blame? Senior اللي كان بالبرايمري كير، senior حط على aspirin. والعيال he's going every time to the polyclinic and they gave him aspirin. So this is a problem. The fatty focal brain cancer. He had a massive stroke, and then he had in the massive stroke, you know, when it's massive, they are prone to hemorrhagic transformation. He had a hemorrhagic transformation. He has cerebral edema, midline shift. He herniated and he died at the age of 62. So it's really it's very alarming with the atrial fibrillation, and nobody actually, except those who are very young and no other risk factor, and we are moving. Before we say paroxysmal atrial fibrillation, they don't need to go for anticoagulation. But now even paroxysmal atrial fibrillation, they should go for anticoagulation. Now it's an increase in those people more than 65%, 10% above the age of 80. Atrial fibrillation increases the risk of 5-fold, so it's a major risk factor. But it's modifiable if you treat it. Account for around 15% of all stroke, atrial fibrillation rate stroke are especially severe and disabling and increase the recurrence rate. Maybe another point then. So if you look here to the age, the age here is just go higher. If you go to the right, and if you see that the prevalence of atrial fibrillation is just increased with age, and if you see the risk, it just substantially goes higher with the increase in the age. So the atrial fibrillation, the more the aging population, it just goes higher. Now, probably the later. Now, see the disaster. Here we have a disaster, okay? And here, this is your rule as a physician, what you have to do. Now, if you look to the red triangle here, those people who ever who have never had a stroke, only 10% receiving therapeutic anticoagulation. Can you imagine? Only 10%. The 30% they are sub-therapeutic, and the rest they are on antiplatelet. Okay. Now after even they declared themselves clearly to the physician, still we have only 18% on therapeutic right now. So we are not doing a good job. We are not doing a good job. We have to think of how we can manage this problem by anticoagulation clinic, alarming. Where is the mistake is coming? Is it from the physician or is it from the patient? Okay, so atrial fibrillation, up to 50% of the patient eligible to treatment receive no anticoagulation at all. And patient receiving warfarin, if we look to the patient who is receiving warfarin, they spend half the time within. They spend only half the time on this therapeutic. And most of the other half is they are either supra-therapeutic or they are sub-therapeutic. So, and this thing needs to. So that's bringing us to ask ourselves, and where is the weakness? Where is the problem with the anticoagulation? Because we are seeing it more and more, and it's very devastating. Now let's switch gear to another thing. Let's speak about dementia. As we said again, the population is aging. This is the main title for me. The population is aging, and you have to be aware of what disease increase with the population. So the country, the government, they should invest. They should invest more. They should invest more money for those people at this age. Now, if you see among over the years, the dementia will keep increasing, and probably the birth rate. Now, the birth rate probably will decrease, and the death rate will decrease. Okay, so we will have a lot of aging population. This is from Australia, and it has been reproduced also from other countries. Now, why I'm coming to dementia? Because look, if you look to the burden of the disease, dementia just has a lot of burden. Ischemic heart disease, stroke, and dementia. Now, I'll tell you a story. Now, I used to work at the Mubarak Hospital just the last week. Then I went to Sina Hospital, and then I went to the ward. And then in the ward, I was shocked that half of the private room, 5 in the female, we have 2 wards, male and female. 5 of them they were occupied by long-term care, advanced MS or advanced ALS. So they occupy the beds. Half of the private room were occupied by long-term care. And the same thing. Then my plan was to do a major round on Sunday, which starts at 7:30. Then I told the nurses, please. So they said, we cannot do this because it takes us a long time for bed care, to do the bed care for the patient, especially because of the long-term care facility. يعني ياخذ يطول على ما يغسلونه, and they change the diapers and they change the bed. It's a hassle to do this. يعني ترمي على المريض وتحط bed sheet. It's a lot of things. So just from this you can conclude what's happening. It's bed, it takes money, it takes facility, nurses. لازم عاد انت تقيس الحين. نيرسز ممكن يصير لها باك انجري. طبعا احنا اول كونتري ما عندنا، لكن هذه تسوي لك انسيدنس ريبورت. هذا باك بين ديو هذا تعال ادفع عاد فلوس سالري and these things because and it's true and she may go in 1 year. Doesn't الحمد لله happen in Kuwait and everybody they will get a back pain. But outside I'm sure Dr. Abdullah and Dr. Ali, they know that this is a North America nurse. أنا شفت واحدة تعملت بس بالترولي في هناك، جتني الله يخليك وقع لي سنة، ما شفتها عقب سنة، ما أدري إيش على شنو وقع. But it's really devastating. So dementia is common. It will become more common. It contributes a lot of disability. It will contribute more in the future. It costs a lot of money and it will cost more. But can we prevent it? هذا السؤال again. Can we prevent dementia? Very hard. But people are working. There is a lot of research centers on dementia. Prevention does not mean that we have to eliminate, but maybe we can postpone the dementia for a few years. And by postponing the disease, this will decrease the burden of the disease in the society and the family and everybody. So if people develop Alzheimer's later, they will have more healthy years of life, and we can say that the disease has been prevented. So that means also prevention by postponing the disease. Now, what's going in the vibe or red vibe as a prevention of dementia? A study from published in the British Medical Journal in 2010, they showed that treating depression and diabetes, you have to treat depression and diabetes because those diseases are associated with dementia. Pseudo-dementia, بعدين تقلب true dementia because of depression. That's true. Pseudo-dementia, and depression then become true dementia. Eating a lot of fruits and vegetables will reduce the case of dementia by 21%. And those fruits, and I advise all of you to eat fruits and vegetables because it contains a lot of antioxidants. Increasing education would lead to an 18% decrease. So education has been shown that those people who are educated are at less risk of dementia. But it has been shown people who are educated at an increased risk of Parkinson, actually, and even more. So choose. You want dementia or Parkinson? Okay. So for Alzheimer's disease, medications such as anti-inflammatory drugs, estrogen, and antioxidants. Antioxidants, they are still working on them. The anti-inflammatory, there was a big study about non-steroidal anti-inflammatory, has been shown initially that's preventive. Then in a major study, they couldn't reproduce the same thing. Now they are studying it again. So it's controversial. For vascular dementia, now the medication that is Aricept and these things, they will الميديكيشن الاريسبت الدونابازين والاذر ميديكيشن اللي هم الاستالكولين استريز انهبيتور احنا نتوقع ان شنو في بالديمنشيا؟ نتوقع ان في لو استالكولين فان احنا ما نقدر نزيد الاستالكولين بس احنا وديكريز ذا ديجريديشن اوف ذا استالكولين فنعطيهم استالكولين استريز انهبيتور الانزيم اللي يكسر. So we decrease the acetylcholine esterase. Now those medications, they don't decrease they don't prevent the disease, but they will hold the disease. And the dementia is under a neurodegenerative disease. Okay, so neurodegenerative will continue. So you would like to hold the disease at certain points without further. And there are some studies which show that people with the dosage right also may improve. Now for vascular dementia, we can do many things. We can prevent vascular dementia, and again you go just back to the lifestyle, antiplatelet, and cholesterol, and hypertension, and diabetes. Two more diseases. So the prevalence of epilepsy around 20%, more seen after the age of 60 because of stroke. If you see a patient after the age of 60, old patient having epilepsy, you have to suspect this use of ischemic event. It's of great importance since it affects people in the reproductive age group, but still she wants to get married. It's the stigma. Now, even for the same for the patient or the guy himself, the stigma to have abuse. And for a female, now she wants to get pregnant, and most of the anti-epileptics, well, some around 50% of them, they are causing teratogenicity, and we know that even epilepsy itself, without being familiar, by itself, it might be increase also the risk of epilepsy and the offspring of those patients. Also, the disease associated with social stigma, which is probably more, we see this more in our community. They think about jinn, مريض طورك طول حياته طاقات يطلعون جن يا جماعه ما في جن الرجال في ابيليبسي فيك محرك جن ام علي في كل مكان. Okay, now the epilepsy impact, the impact of epilepsy not only on the patient but also on the family and the community. Most people they cannot drive, you cannot drop these kids to the school. In fact, you should have you should have a driver or the wife should drive now. So this has a lot of pattern. Also the pattern from the physical hazard لو هو يشتغل في شغل يعني in a certain job أو طبعا احنا we prevent them, it depends on the job. لو واحد يشتغل في machine which is tough or cutting or something, we should prevent them from doing it. بس ساعات يعني تعرف يعني هذا مصدر رزق حق الانسان يقول لك قطع الارقام ولا قطع الارزاق يعني لازم and they go and sometimes they may have the epilepsy during their job, so they may have a devastating injury. Another thing, maybe the first episode of seizure happened when they are doing واحد قاعد يركب سقاله وقاعد فوق مسكين طاح من فوق the first attack. So this can happen at any time. So the hazard for seizure is, or lots of people that are drowned because of the epilepsy, and kids. I've seen it in kids also. And also there's social exclusion. So children with epilepsy may be banned from school, others may be prevented from marriage, either because of their low self-esteem, mindset, and their encouragement to get married, or even people once they ask, they الرجال هذا فيه ترى صرع ما هو صرع فيه لا بعدين but people they just go away and they think of just right away. And maybe from marriage and employment is often denied. انت الجوب الحين لما تجي تكثر يقول لك تعال دكتور عطني تقرير تقول لنا ستيبل ولاق للعمل لكن الجوب حتى لما تجلس people they sometimes even they deny those people because they think of the risk or the burden of this guy on the ليش فيها insurance. Associated with the significant psychological anxiety and depression and poor self-esteem. Okay, what shall we do? Now we can do something for epilepsy. We can prevent in terms of prevention. Okay, protection from head trauma. Head trauma is a major cause for epilepsy. Now, if you advise people, seat belts. I'll tell you a story about this because I like to mention the story. And it's still within my time because I started late. When Nora, صح? And I'm still with it. I still have maybe 10 minutes more. لا والله I started late. Okay, I'll tell you a story. طبعا خليك من الكار سيت. It happened to my friend. طبعا الكار سيت الحين بالكويت ما في واحد يسوق وولده بيده ما شاء الله مستمتع بالقياده. نيونيت تو ما ادري شلون هذا ممكن يعطيه بعد ممه اذا احتاج. What happened طبعا كندا لازم تشتري الكار سيت قبل انك ما تشتري السياره. But one of my friends actually they were driving from I used to be in Montreal. They were driving from Montreal to Niagara Falls. And then during هذا he gave him a ticket أعطاه مخالفة عشان سايق أكثر من 120 يمكن 122 يعني. ف يا ريال oh there is a baby here in the back. يقول إيه يقول له ولدي ما بيجي. يروح يشيك على السيت بيلت مال الولد هو محطوط بالهذا. يقول you see this is loose. يقول له ها زين يعني ايش كثر اربطه اكثر يعني no this is loose كان يعطيه another ticket اعطاه ticket طبعا you can imagine how people they are very strict with the car seat and it has been shown يعني خلاص الناس ما راح تسوي لك استدعي عشان كار سيت عشان الكويت والجي سي سي يحطون عيالهم في كراسي خلاص انتهت يعني كار سيت is very important to protect the children from head trauma and again wearing a helmet it has been shown a lot for bicycle and motorbike to reduce. Now, if you look from South America, the commonest cause of epilepsy is the neurosystem psychosis. So they have to work hard to prevent the neurosystem psychosis. Cooking, handling, from tinea شنو؟ وين الشطار؟ وين ال A student will be؟ ولا كله ديز و حميد؟ tinea solium. Neurosystem psychosis. Okay, now you can use also infection by taking infection during pregnancy. During and you did not treat the lady well during the pregnancy, then the child will be out. You have to treat the infection during pregnancy. Therapies and these things is very important to reduce the risk of neonatal meningitis. And then because if the risk of neonatal meningitis increases, the risk of epilepsy increases. Because you have to, and that's why they do herpes simplex virus type 2, and I have seen it also in the patient who was not treated. The child did herpes and they have meningitis, and after 10-15 years, they have a prone to epilepsy, hippocampal sclerosis. You see the hippocampal sclerosis after 15-20 years. Has been well known. Commonest, أول ما أشوف واحد young, you have to ask about the three things: neonatal meningitis, head trauma, and febrile convulsion. And febrile convulsion also has been shown you can prevent it. يعني أنت تقدر تحاول تخليها من simple إلى complex if you don't abruptly give them the paracetamol or the drug to lower the fever. Reduce strokes, as we say, encourage compliance with the medication. Now, this is the main reason that brings people to the status epilepticus. Gene therapy may be in the horizon. Headache. Headache is the commonest neurological problem comes to the attention of a primary physician. The problem is growing, and we are a cause actually of this problem growing. We'll see why. The problem is growing and the problem is growing because of the medication overuse, headache, and chronic headache. We are not putting a lot of time to treat such patients. Around 50% of the patients in the headache clinic are medication overuse. زين منو اللي سوى المشكله بالميديكيشن اوفر يوز؟ يعني انا عندي مثلا هيديك كلينيك، الاخذ ذا يقول لي دكتور، يعني اقول له ليش تعال؟ يقول الدكتور ما قال لي. في البرايمري كير انا رحت للدكتور بس والبيشنت از ليجيتيمت يعني قاعد يعطيك جود ستوري and he will tell you the doctor did not tell me how much I should take. فهو ممكن البرايمري دائما نقول يعني we have to encourage people in the primary care because they are the first entry point. هذا السيستم برايمري كير، سكندري كير، تيرشري كير. في البرايمري كير انت يو هاف تو نو، فهم خلونا ممكن يخلقون لك مشكله either they treat well for example primary care they should not put them in care with a lot of patient medication overuse headache, and if they treat well they will prevent the patient from being the chronic cases of headache. So and again if you first step to treat headache is to classify it by filter, they don't spend enough time. It has been shown that people with the medication overuse and chronic that they will tell you that the doctor they did not spend time telling us about the disease. It has its own burden, and why it has a burden? The burden of the medication overuse is really high. Those patients they come more frequently to your clinic, and I stuck with them because they reduce other patient number. They will come more frequently to the clinic, and they will come more frequently to the emergency room. So it's better to prevent and to avoid the chronicity, which is more bad. And I can avoid it. You have to educate the patient, treat well, choose the appropriate medication, and you can prevent chronicity, and you can prevent medication overuse. Patients with medication or chronic headache, they need many days off. هذا لازم تلاحظ الشغلات هذه ان الناس هذول يحتاجون وايد days off وياخذون معاشات خلال هذا بيردن ترى على الدوله على المؤسسات الحكوميه. So you have to take it into consideration. Therefore, spend time in education the patient. Doctors, they should spend more time. Identify if there is a social factor. Those people, they may need, and you're spending time and time, but they may need psychotherapy to finish the problem. Treat effectively and use appropriate preventive treatment to prevent medication and chronic headache. Now, it's true that there are lots of headache types, but there are those alarming things for you. Not every headache is a primary headache disorder. You should be aware about secondary headache, and those people, you should just refer them and do the appropriate things for them. And this is the abbreviation for this SNOOP, 4P. If there is it's not a primary headache if it has systemic symptoms, fever or weight loss. This is not a primary, this is not a tension, this is not a migraine, this is not a cluster. You have to think of something else. Okay? Secondary risk factor, like HIV or cancer, he needs more time, he needs more investigation for such patients. If the brain has a neurological symptom like confusion or the onset يعني ما واحد على age of 70 and you tell me he has a migraine, so it's not the age of primary headache disorder, and it is abrupt like a subarachnoid tremor. Older patients you have to be aware of giant cell arthritis, okay, and the best test for this is ESR and C-reactive, but the gold standard is biopsy. Okay. Previous headache history, if it's changed, and papilledema, and if it's precipitated by valsalva or postural aggravation. يعني معناتها ان احتمال شنو؟ space occupying lesion، صح؟ increase intrathoracal pressure. خلاص take home message. So the take home message we have to know مو احنا بس you as a physician هذا حق الناس اللي تبي تطلع تدرس برا يمكن احتمال انكم اتوقع ان the money people who do geriatrics or maybe you have to do dementia, the patient is growing. Disease that happen at older age people. Healthcare system also the government they should be aware of about. I think we should have LTC ولا شو رايك دكتور عبد الله يعني well, I don't have يعني I stuck really يعني I told you the story. وين اوديهم؟ They are a big family to be honest with you in Kuwait and they have no solution. I went to the director of the hospital and he told me Jاسem there is no solution for this. زين وين اودي النيو patient؟ ما ادري. And we are therefore, I think we should build a building with a facility. With the, there is a plan. Okay, after 10 years. Okay, more research are needed in this area. That's my talk, and any question, I'll be more than happy to answer.
Doctor, about multiple sclerosis.
Yes.
I think that it was having a high incidence here in Kuwait in the previous years.
In 2005, 2006, multiple sclerosis had high incidence here in Kuwait. So what did you do about this to decrease the incidence?
Well, you see, if you look to the paper, I published a paper looking for the prevalence of multiple sclerosis in the Middle East. Not to say that I published, but it was one of the best probably paper with the help from Miguel epidemiology department. And the prevalence of multiple sclerosis in all over the GCC is high. بكل منطقة الخليج is high, okay? But it's underestimated. And the way to look at now, الحين الMS لازم الحين تعرف the MRI came in 1986 here in Kuwait, okay? And before that, not every case when they see a white spot in the brain, they will say it's a MS. Now we have overcalling. We are overcalling. I mean, ليش? Doctors, they are more aware about MS. Radiologists, they are more aware about MS. فلو يشوف له نقطتين ثلاثة, he will call him MS. And the machines are very good. تخيل التلفزيون قبل 5-6 سنوات طلع لنا البلازما، الحين LCD، الحين the resolution is so high for every, and we have overcalling. We are overcalling. We wide misdiagnosis. But I have to tell you the truth. We are just knowing that this is our prevalence. The prevalence is not increasing, but we are more aware, and that's happening all over the GCC. I think our awareness about multiple sclerosis has been increased. Yes.
Stroke secondary prevention.
Yeah.
If a patient has atrial fibrillation and you give him anticoagulants, would that increase his risk for transformation?
So it depends now if the patient it depends on the time. Now انت طبعا patient انت قصدك patient جاي acute stroke صح؟ هذا قصدك؟ عنده acute stroke عنده atrial fibrillation. There is a time window. It depends on the stroke size. Now the highest time for hemorrhagic transformation طبعا you cannot anticoagulate him right away for sure. انا قاعد اتكلم عن الكرون. بس in هذا you have to wait for 48 hours because this is the maximum time of hemorrhagic transformation. And also it's the maximum time for extension for any bleed. حتى لو واحد عنده intracerebral hemorrhage, the maximum time for this intracerebral hemorrhage انه يصير عود 48 hours. عقب 48 hours you can start. لو كانت big stroke الريسك عالي انا I wait for 1 week. There was a study they looked at حطوا patient بسرعه anticoagulation حطوا patient عقب اسبوع anticoagulation ما لقوا فيه difference. فقالوا احسن ان احنا ننطر ولا نزيد الريسك of hemorrhagic transformation. Okay, risk is the same. So you just wait and anticoagulate. تعيد الCT إذا ما عنده hemorrhagic transformation then you start safely. Any further question? Okay, that was great. Bye bye.